the room is filled with enthusiasm. I mean, what intensities. Guys are terrible. All right. And I'll enthusiastically begin. And I know we were here, but just to quickly go over it just a little bit. The autonomic nervous system, and you've seen that, and you've seen that. Really, this is a very interesting, and the first thing is terminology. It's a two-nerve circuit. Again, since the cell body is not part of or incorporated within the central nervous system, by definition, we call it a ganglion. So the terms that you have to get used to are pre and post ganglionic pathways. So you have the preganglionic nerve and the post ganglionic nerve. Okay, well, I don't really worry about lightly myelinated or non-myelinated at this point. It's not nearly as fast a system as the skeletal nerve, that we have discussed in earnest. So again, the autonomic nervous system, it's good. Preganglionic fibers release acetylcholine. You will see shortly, by definition, we have given the receptors a name that are on the postganglionic dendrite or receptor portion of that particular nerve. Interestingly, those are called nicotinic receptors because they found when nicotine, they isolated the active ingredient, they isolated the chemical nicotine in the 1800s, and we're interested to find that one of the things it did was it basically triggered these same nerve endings in the autonomic nervous system. So they refer to all of these as nicotinic receptors rather. And all the postganglionic fibers, it's either norepinephrine or acetylcholine. And again, really you're going to look at whether it's excitatory, inhibitory. Again, it's all about exceptions. Most of these are excitatory, depends on what they're doing. And particularly when we get when you see in the parasympathetic system, the big exception, and I pointed it out to you before, is it slows down the heart rate. It doesn't necessarily affect the muscle per se. It's all about the heart rate. Where in the sympathetic nervous system, it has a whole subset of different receptors. And you'll see the name, they even have a name of the receptor in the parasympathetic system. It's called muscarinic. You'll see the names, so I'm not writing them down or anything like that. But what's really interesting is when you get to the receptors, and that's really a significant piece because this is where a lot of medications that people have prescribed to them, we work through things with a lot of this one you're going to hear about, where I can't classify it just off the top of my head as either excitatory or inhibitory. It depends. Whether you hear about alpha 1s and beta 1s and beta 2s and alpha 2s, et cetera, et cetera. So that's where the complexity comes in when we get to that aspect of this nervous system. So, yeah, it's regulated and coordinated, even though it's autonomic or automatic in nature. Active muscles require more oxygen and glucose, so autonomic nerves speed up heart rate and open airways. That's the classic example. If you want to understand this system, the best thing is to understand what fight or flight is. Fight or flight is what we call the sympathetic action division. And we studied a little bit last term about what happens in the nervous system. Fight or flight is just that. When you're placed immediately in a dangerous situation, it doesn't have to mean someone's coming to attack you, but it could. It doesn't mean someone's chasing after you, but it could. Okay? It could be you just started a workout. That really mimics fight or flight. When you're in a full, anything like that. There's a lot. So when you become active, it's varying degrees of it. Instant fight or flight is really a dramatic change, and it's nearly all pure sympathetic activity. So what happens? Your eyes are wide open. It means the pupils are maximally dilated. It's designed for distant vision to see everything way. So the lens is flat. That goes along with pupillary dilation. We learned about that a bit last term. We talked about things with the nervous system. Your respiratory passageways are fully dilated to get maximum air because your lungs are pumping maximally, your heart's pumping maximally, your blood supply has been diverted to your heart and skeletal muscles. Your blood supply has been restricted dramatically from going into the genitourinary and gastrointestinal system. Okay, blood's been redirected again to skeletal muscles to the heart, and in the meantime, limited to everywhere else. That's kind of what happens. Immense amounts of signals, depending on how much you have to prolong the activity, go to the adrenal medulla, not the adrenal cortex. The medulla is really part of the sympathetic nervous system, and it dumps not only norepinephrine, but an additional chemical just like it, epinephrine, another hormone. And basically, that will even prolong. So whenever fight or flight happens, and that idiot tries to cut you off, well, how long do you know it? Racing, your heart's racing, you're sweating, you're oh my god, like that. It takes a little while to recover. That's the prolonged action. So if you remember, fight or flight is nearly pure sympathetic. Everything else is parasympathetic. Just go in the other direction. The heart slows down to its usual rate. Your breathing goes back to normal. At rest, typically your eyes are usually more constricted, more designed for near vision than far vision. The blood's being distributed appropriately, etc., etc. Everything gets reversed. And we'll see that it's not all dual innervation. Again, you're going to want to memorize the exceptions. That's how things work. The trick to memorization, when somebody's got a really good memory, is don't overload with a lot of stuff. I love doing all that stuff. But that's me. Like I spaz out if I don't remember something. I gotta look it up right away. I don't ever want to forget that again the rest of my life. Okay, here, typical somatic nerve, highly myelinated, all those lovely dendrites, the axons, acetylcholine, bam, stimulatory. Not worried about the myelinization, okay? The sympathetic, a two-nerve chain, here's the ganglion. Typical ganglion is very, very close, as you will soon see, to the spinal cord or the spinal column, and it's strictly in the thoracic and lumbar area, even though the rest of it goes all over. So you're going to see that the preganglionic fibers are relatively short, the postganglionic fibers are relatively long. The oddball is this one. We think that the adrenal medulla, lying in intimate contact with the blood supply of the adrenal gland, is most likely a misplaced ganglion. I subscribe to that theory as well. And it releases both epinephrine and norepinephrine. All the other ones, other than that, just norepinephrine. Short pre, long post. Other. This is the craniosacral division. It involves you have to know all four cranial nerves. I talked about that last time in anatomy. That's nerves 3, 7, 9, and 10. 3 does the whole eye thing, the dilating the pupil, the lens, etc., that thing. 7 and 9 are mostly salivary gland orientation. Okay, and 10 is the vagus nerve, the longest nerve, the only nerve that goes outside of the head and neck area, and that's the one that goes to the vast majority of the organs. To simplify it, you'll have to look at it again with the diagrams that are here. So it has long, the vagus would make you remember that, long pre, short posts. And it's acetylcholine and it's acetylcholine. You're going to see there's an oddball here. Remember the oddballs. You see Robert Duvall died today? Who is that? Jeez, you're just awful. I was in Godfather and Godfather 2, Apocalypse Now, more recently in some other stuff, 95 years old. Did you ever have to read To Kill a Mockingbird? They made a movie in 1962 with Gregory Peck, and he played Boo Radley, who everybody was afraid of, but turned out to be the good guy, type of thing, So that's where he first came. That was 1962. Very good book by Harper Lee. If you didn't know, Harper Lee's a lady, but they didn't. This is an aside. They had lady. The literary field was the same type of thing. It didn't give a lot of credit for women, so I think her name was Katie Harper Lee, and they just put Harper Lee. And she played a really important role with Truman Capote and traveled with him when he did In Cold Blood. Not a book that you read, or In Cold Blood. He basically went into detail to try to understand two guys who killed a couple who they thought had money who didn't, and their whole family. And followed it right through to the termination portion of the death sentence. Right? Yeah. So he went there and got close to all the family. Very strange, very interesting fellow. God talks to you. Okay, we're moving. I didn't want to miss anything. Dual innervation. I love the term dynamic antagonism they use. Okay, the parasympathetic, what you're doing now, and I can see it, very low energy levels. You got to stop drinking all night long, you guys. You really have to stop this. You got to be careful. So we call it the rest and digest. And basically, when we're resting, all of these things, our blood supply to the genitourinary and the digestive areas, gastrointestinal area, that's when your body is busiest taking care of maintenance issues. Well, you get up in the morning after you've been in bed, typically have to go to the bathroom, that type of stuff. That's all part of this rest and digest system. You're doing it now, which is the only explanation why people are constantly getting up when I'm talking, running to the bathroom. I'm the old guy who's had prostate surgery. I should be running. You're all looking at me like, what is he talking about? Just wait. So, person relaxing and reading after a meal, blood pressure, heart rate, respiratory low, GI, pupils constricted, typically closed vision. You're doing what you're doing here now. Sympathetic, fight or flight, the action division. All of these things will trigger it. I forgot to mention, secretions dry up, okay, because that way you can respire better. We intentionally do this when someone has an operation. When we have an operation, you have to intubate somebody. It is very difficult if they have an abundance of yuck in that area, saliva and mucus. So part of the preoperative orders or the preoperative meds, they may use them differently today, but one of them, and this is where it'll come into when we start seeing the receptors, will be designed to block those secretions. So it will basically make sure that does not it's going to mimic this activity. So it's going to address the secretions. You want to generate a dry mouth. You want to be careful with heart rate, so it has to be very, very specific. The circulation is diverted from your skin, but not, it's sort of misunderstood. It's somewhat diverted from your skin because it's brought internally in fight or flight, but you have to have enough innervation for perspiration because that's going to be cool and you're generating a lot of heat. And again, the pupils are dilated. Muscles, skeletal muscles and heart, dilates the bronchioles. This is, you used your stored energy. You only can store glucose for emergency energy in two areas, the liver and skeletal muscles. It is an emergency response. As soon as this is done, your body turns around. What does it do? Basically, you create a certain amount of lactic acid. It changes that to pyruvic acid in the liver. The liver glycogen is restored because you're going to store some of these carbohydrates. You're going to do some gluconeogenesis. You're going to store some carbohydrates as glycogen, and you're going to go and replenish the supply in your skeletal muscles. Whether or not you are, the analogy I use with the nursing students is the crash cart. So if you're familiar with how a hospital, whether it's mostly an emergency room, you see it more else, but anywhere they'll have a crash cart. When somebody starts to code out, their heart stops, and you have to do heroic measures to resuscitate them. If you have not seen one of these, it is a mess. Stuff's everywhere because your goal is to keep the person alive and get him to come or her to come back. So you've got stuff on the floor. You've used stuff in the crash cart. The first when someone's going to get that patient, it's one of two outcomes. They're either going to be alive or dead. Hopefully, they're going to get them someplace where they're going to be able to maintain alive. The room is a mess. Someone's going to clean up the room, but the first order to anybody who's either in charge from nursing or doctor is reload the crash cart because you never know when the next emergency is coming. Your body does the same. You'll see that if you go out to work in a hospital, if you get one, it's a crazy day immediately. Watch out if you get two because there's a third one coming your way. Well, it comes in threes. We have those. If the second one came in, the first one's like, oh my God, there's going to be another one. Everybody telling you exactly what happens. So just be aware of that. Three main differences: parasympathetic fibers, cranial and sacral. 3, 7, 9, and 10. And I think S2, 3, and 4, they'll show you here, they originate in the brain and sacral spinal cord. So obviously, if you think of sacral spinal cord, this is going to play a pivotal role in sexual function and or dysfunction. Sympathetic fibers are thoracolumbar, originate in thorax and lumbar regions of the spinal cord. Paras, long then short, sympathetic short then long, however you want to remember that. Parasympathetic ganglia are close to the organ, close to the heart, close to the liver, wherever. Sympathetic ganglia close to the cord, with the exception of the adrenal medulla. So, and you'll see this chart a number of times. And the first thing to notice is what it does cover or what it doesn't cover. So you look for the areas. Doesn't say skin over here. Okay. So that little asterisk got to tell you something. Doesn't say skin over there. Genitals, we'll buy it. Bladder, adrenal gland, only here. Skin, only here. Salivary glands, heart, lungs, stomach, pancreas, liver and gallbladder, bladder, adrenal gland. 3 areas. Genitals, adrenal, and they have even a slightly different color. Salivary gland, or beg your pardon, skin, adrenal gland, and as you can, pardon me, adrenal gland and skin. And I missed one. And the thing that's conspicuous by its absence here is the single most important part: blood vessels. There is absolutely zero control of parasympathetics on blood vessels. Your blood pressure, ladies and gentlemen, has everything to do with your, we call it sympathetic tone, known as vasomotor tone. Vaso for vessels, motor for their muscles, tone, how loose or how taut. All about blood pressure. And because it is all about blood pressure, the organ that is not innervated at all by the parasympathetics and its function effectively is mandated by the amount of blood flow, either too much, too little, not enough, is the kidney. That's why if your blood pressure goes low, your kidney has one response. You've already heard me say this: to blood pressure that's falling, it shuts down. Kidneys shut down at everything. Not enough blood pressure, have an infection, have trauma, they shut down. The word we give that is shock. In this case, vascular shock. Moving on. So they give you the idea. It's S2 through S4, as I recall, 3, 7, 9, and 10. Thoracolumbar, T1 through L2. And you can read through this. I don't worry about the rami communicantes, but all of this is very, very relevant. So the craniosacral division, we start with the parasympathetic. Again, brain and sacral regions. Terminal ganglia that are close to or within the organs. Same illustration. Oculomotor, 3. That's ciliary ganglia, the smooth muscle that basically impacts the pupils to constrict and the lens to bulge, or if the pupils dilate, if it's not working, the lens will flatten. So that is the gland. It's basically affecting glandular structures. My name is the ciliary ganglia. That whole thing with the eye, got it. Facial nerve stimulates large glands in the head. So you have nasal and lacrimal glands, pterygopalatine ganglia, submandibular glands, etc. So the big ones are submandibular and sublingual. Again, that is why the concern is that if for some reason there's difficulty with respiration, You have to find a way to dry up those secretions. And then this is not a whole lot different. The largest of all salivary glands are the parotid glands here, just external to the masseter muscle. You have the zygomatic arch. You can feel that fleshy area here. Those are your. They are probably the most generous, and it's, you might recall it's kind of watery. It's a serous drainage. And the vagus, 90% of all preganglionic fibers, chest and abdominal viscera, and there's a lot of different names. These different plexes that are associated with it. We're not going to go into it. To me, that's graduate anatomy. But branches to the stomach, liver, gallbladder, pancreas, small intestine, and even part of the large intestine. It's busy. S2 and S4 serves the pelvic organs and distal half of the large intestine. Okay, so distal half of the large intestine, the colon, that's the remainder of the colon, bladder, ureters, reproductive organs. Notice, no kidney. Sympathetic, other side. So here's the parasympathetic diagram, rather, and here you can see the sympathetic diagram. So you're going to see that this is really the interesting part of the relationship vis-a-vis reproductive function. And here, everything else kind of. Sympathetic, a lot more complex and more structures. You know what I say about the word only? Not a whole lot of onlys when we deal with science. Onlys and nevers. Sweat glands. That's the oddball of acetylcholine being released from the sympathetic nervous system. The erector pili, making your hair stand on end. Another thing, whatever you want to call it, goosebumps, I don't care. I have no idea what the modern vernacular is. Do let me know. I'm sooner or later I'm going to have a grandkid the right age for all this. But I'll be in a good mood on Monday when you're taking the test because we are, that's right, babysitting again. My wife's welcome helpers, unpaid helpers. She'd yell at me if anybody came over. I don't need anybody's help. It's a baby. Sweat glands, erector pili, smooth muscles of all blood vessels. The biggie. There it is. There it is. And the fact the adrenal gland position really is not relevant to they should have pointed that out as well. And they deal with, this is some of the anatomy. I don't want to do it. The paravertebral, this is called the sympathetic chain. It's a series along here. Years ago, that we used to, before we had more advances in vascular surgery, to try to increase circulation, the theory was if you tore those out, remove them surgically, do what's called a sympathectomy. Reflexly, it should dilate the blood vessels. It didn't work. I remember scrubbing in on a couple of those. It's a chest surgery where you actually go into the thoracic cavity and remove that. All of those, you go in by way of a thoracic thoracotomy, go in and do that. And they never worked. There's so many. This is in the early stages of bypasses, in the early stages of stents, and we didn't have the technology or the advances to do those things. I'm just mentioning that as an aside again. So again, where they synapse and collateral ganglia don't care. Rami and rami are just branches that communicate. And so again, it depends. I mean, this is an elaborate structure here. That's that dorsal root ganglia. That's the sensory nerve. So that is, that's not part of the sympathetic. But the sympathetic chain would start here. Again, it starts as a motor nerve, and then this would be where, and it would start here. These would be the ganglia, and then branches would come out from that, so to speak. And they're just trying to give you an idea where it might be going to, whether it's a blood vessel or an erector pili, etc. And then there's a whole number of these ganglia that I also don't go into. So I'm not trying to make it as, from an anatomical perspective, I'm not trying to pay a ton of attention to it. But where they go, skin and blood vessels, dilate the iris muscle so that dilates it, inhibits nasal and salivary glands, things going to the heart. Again, heart via the cardiac plexus, thyroid, lungs, and esophagus, all these different pathways. These, they used to call this area, okay, they had the splanchnic or splanchnic, and this was really one, the celiac superior. Remember, you saw those names before when we looked at blood vessel anatomies, remember? Had the celiac arteries, superior and inferior mesenteric arteries, for those who were with me in anatomy. In the old days, they used to call that the solar plexus. So if you struck somebody, you could disable somebody, potentially really do serious harm to somebody, when you struck them right under the diaphragm, right under that xiphoid. And so that would be like that. And then you would stun, and it would stun them. So that's why I don't know what they do with mixed martial arts and that kind of stuff, but I'm sure the training is similar. They're very, very rigid abdomens. They do a whole lot of ab work to make sure that that's, that protects it with the muscles, I would guess, because boxers do. I'm more familiar with boxing historically than any of the more modern sort of combat sports. And so all of these synapses, wherever they are, various things in the abdomen, down to the pelvis, all of these areas primarily inhibit activity of muscles and glands in the abdominal, pelvic, visceral organs, basically. So, so the medulla, and again, considered a misplaced sympathetic ganglia. Most people concur with that. The medullary cells secrete norepinephrine and epinephrine. Years ago, they were called noradrenaline and adrenaline. So it should be also called noradrenaline. I should say adrenaline. That's a misprint. But now we continually, but you'll hear that. Okay, I mean, historically, see, we're looking at give somebody a shot of adrenaline now. It's correctly epinephrine. And we're all familiar with an EpiPen. And you'll see the reason why we use an EpiPen rather than a ballpoint pen, to be facetious. An ink pen, a Sharpie. I can't breathe. Give me the Sharpie. I thought that was clever. Now my mood is worsening. You at least could be laughing. It's okay. This could be a laughing at me rather than a laughing with me. I can live with that. I should really have my wife sit in. She'd go, I'll tell you, he's not funny. Okay. So moving on. And it's a little bit different. They're just showing it to you. And all of these things, visceral reflexes, things you don't have any information about, chemical changes, stretch receptors, irritation of the viscera, the things that they're so non-specific. I mean, we know a little bit if I feel full and I don't want anything, or I feel bloated, or there's irritation. We get sort of general signals rather than very, very specific signals. Okay, so and sometimes there'll be convergence in different areas that are there, and they talk about the arcs that are there. Okay, so reflexes that empty the rectum and the bladder. So again, they're sending you those signals. It comes to your attention that you have to void or have a bowel movement, that type of stuff. And basically your internal nervous system, your enteric nervous system, kind of takes everything for itself, and then and then basically you have an idea of how urgent or unurgent the problem would be without putting too fine a point on it. We really, for me, the crux of what we're learning about, other than that base anatomy, long pre, short post, short pre, long post, and the exceptions of where it doesn't necessarily stimulate or does necessarily stimulate, is here. Okay, neurotransmitters, acetylcholine and norepinephrine. The name of any fiber, including the neuromuscular junction, okay, is a cholinergic fiber if it releases acetylcholine. So all preganglionic axons are cholinergic. All parasympathetic postganglionics are cholinergic. Doesn't have to do with the receptors just yet. Okay. And we use the term adrenergic fibers for norepinephrine. Almost sympathetic postganglionic axons, except those sweat glands, which happen to be cholinergic. That's the oddball. Remember the exception. So there's a terminology, and I'm telling it to you for a reason. I don't know where you're going career-wise, but some of you are going to have to learn about anticholinergics, okay? Adrenergics. The names are going to come to you. And we haven't even started yet when it comes to that. Basically, there's a whole series of pharmaceutical agents that either mimic or oppose one of these systems or both. So you're going to hear terms like sympathomimetic. It mimics the sympathetic nervous system. Speed does that, amphetamines. Sympatholytic, it blocks the system. Parasympathomimetics or parasympatholytics. So if it's a parasympatholytic, it basically mimics the activity of sympathomimetic. So you hear those things. I don't want you to be confused about them. I'm not sure where you're going career-wise, but I would prefer that you are aware of this terminology. So when someone uses an EpiPen, that is a sympathomimetic agent. Specifically, you're going to see it's targeting a beta-2 adrenergic receptor. I know you're excited about that. I can see. Same picture you saw before. Here we are, nicotinic and muscarinic. It's very interesting. Nicotine is an unusual substance. It's highly addictive, extraordinarily so. It's one of the most highly addictive substances, but believe me, I'm telling you chapter and verse about this. And what makes something addictive addict you rapidly is to how fast it gets into your bloodstream. And the fastest way is, that's right, inhaling it. So if you're basically inhaling fastest possible way a substance, it's highly addictive. So we'll start with that being a problem. The fact that it targets both of these systems mean it's effectively stimulating them both simultaneously. So for instance, before we would take an exam, and most of us in medical school smoked. Before we took an exam, we'd be outside of the classroom because you could smoke in the building, smoking. And then when we were to get ourselves ready to go, and as soon as we got out, we lit up to calm ourselves down. Go figure. So I mean, there were a whole lot of 2 and 3 pack a dayers. Not that terribly long ago. I know it seems like ages ago. So named after the drugs that bind to them and mimic them. Nicotine does so at where the receptors on the postganglionic fibers, and muscarine, which is a poison they derive from mushrooms, happen to do that on muscarinics are on the postganglionic fibers of the sympathetic nervous system. So all postganglionic neurons, sympathetic and parasympathetic, hormone-producing cells of the adrenal medulla, skeletal muscle cells, is always stimulatory and rapid, opens ion channels to polarizing the postsynaptic cell. The fastest way things work is when they open ion channels. Muscarinic, all effector cells stimulated by postganglionic cholinergic fibers. Okay? So the exception in the sympathetic nervous system is basically to generate the sweating mechanism, and everything else is all the other ones are in the sympathetic nervous system. Inhibitory or excitatory depends on the type of receptor. Here's the big exception. Acetylcholine to cardiac muscle cells And it only affects the heart rate, not the force of contraction. Whereas what keeps your intestines so busy when you're at rest is this is a very active system with a lot of blood supply, and it's increasing smooth muscles, smooth muscle activity and motility or movement in the gut. And so now, and these are the others, the alphas, alpha 1, alpha 2, beta 1, 2, and 3. You're probably going to need to know an example of alpha 1, alpha 2, beta 1, and beta 2. And it depends. Norepinephrine binding to cardiac muscle, beta 1. Receptors cause increase in rate, whereas epinephrine causes bronchial relaxation when it's bound to beta 2s. Those are your two big examples. And not only does it increase the rate at the heart, it increases the force of contraction. That's a big difference. When we get to cardiac, you're going to hear about chronotropic, rate, chronos for time, inotropic, don't know how they derived with the inos, I mean, that's force of contraction. So acetylcholine is negative chronotropic, where epinephrine or norepinephrine, which will both work similarly, are positive chronotropics, decrease the rate, and positive inotropics to increase the force of contraction. That'll be a question when we have our cardiac. We do that one in lab. For a one PowerPoint sequence chapter, it's a lot of info. You don't have to thank me. It's all part of the service. Is it me? I can't read this. I hate this. I can't read it now. It's so big. Could you read it up there before? That's not fair. You're sitting close. If I said Mr. Magoo, would it ring a bell? No. The old cartoon. Go look. It's my wife calls me that. You couldn't see anything. The late Jim Backus, great voice. Nicotinics, muscarinic, all postganglionic excitation. Excitation in most cases, inhibition of cardiac muscle. And again, sweat glands. It activates them. So it's not, I misspoke. I mean, it's basically, even though it's doing something that you think might be the reverse, it's actually activating. That's okay. Adrenergics. Okay. Beta 1's heart, also kidneys and adipose tissue. A lot of the energy gets derives from that. That's one of the advantages people would have thought when you're doing it. It's pitfall because they used to use for dietary purposes to try to lose weight. They give people these kinds of stimulants like speed, amphetamines. Trouble was they had high blood pressure, their heart rates were very, very high, even though it was gobbled up fat. So I mean, it was accomplishing what it was, but with no limitation of complications. Lungs and most other sympathetic target organs, blood vessels serving the heart, liver, and skin. What happens? We dilate the bronchi, we dilate the heart, we increase blood flow to the liver because that's where effectively our source of glucagon and our source of glucose-like products are coming from to serve glycogen rather from fight or flight and skeletal muscle. So it affects mostly inhibitory, dilates blood vessels and bronchioles, relaxes the smooth muscle walls of all those things, and even relaxing the uterus. So down the road, it plays a bit of a role with regard to reproductive processes. And here's the one for adipose stimulating fat cells. The alphas, all sympathetic target organs, especially blood vessels serving the skin, so we don't get as much blood flow to the skin. That's why it's somewhat confusing because it is going to sweat glands. Abdominal viscera, kidneys, and salivary glands. Constricts those. Okay, while yet dilating the eye because we're redirecting the blood up here. And alpha 2s, membranes of adrenergic axon terminals, the pancreas, inhibits norepinephrine release from the adrenergic terminals, inhibits insulin secretion. When your sympathetic system is active, typically we utilize insulin and carbohydrate usage when we are at rest, not when we're active. We use fats as a fuel source, as you can see, with the adipose tissue, so not that. So that's just one you just have to remember based on what I'm telling you, more than anything else. Help, help. And here are just some examples of some of the agents. Nicotinic agents. They're the easiest ones that you can think of because basically smoking should say whether it's patches, whether it's gum. And the reason we use them, there's no pill because nicotine is deactivated by stomach acid. And people use them for a lot of different things. Okay, so it's not all, but that's their categorization. Stop smoking products. It didn't work for me to stop smoking. I was smoking with them. It's terrible. Here are parasympathomimetic agents. Enhance parasympathetic activities, mimicking the effects. This is for glaucoma. I don't know if this is currently in use. Maybe it is. I would ask you about it. One of the interesting things that men particularly get when you're older because of prostate is problems urinating or voiding. It's typically prostate related. They are consistently trying to find agents that work for that. This was one. I do not think it is terribly effective or used today. They actually are using, I think, an alpha-1 blocker more than anything else. And I'll have to I will find that out for you because the one I did use that helped the most with my bladder cancer that in the complication of that was causing my bladder, causing my prostate to become hypertrophy, and it had to be resected. So they give you it's Flomax, which has much less side effects than a lot. So you get somebody, with prostate or bladder problems, they're on Flomax. Acetylcholinesterase inhibitors. You already heard about those. Both of these. Chemical weapons, nerve gas, or neostigmine, which is something for myasthenia gravis. So, one, chemical warfare, weapon of mass destruction. The other for myasthenia gravis. It's there. So, they're not all necessarily things that are commonly used. Sympathomimetic agents, very commonly used. Okay? So the enhanced sympathetic activity, and I'll give you the pharmacology. This is the one, and everybody in this room knows somebody or they themselves have to use a bronchodilator. At the very least, any of these bronchodilators with Ventolin being are beta 2 stimulators. Okay, by definition, they're sympathomimetic. They have been very successful. A lot of people use those, and there's a lot of things. It's not always allergic-based asthma. There's a lot of triggering factors that are there, and they have been a really valuable way of treating. Also, they'll very often have steroid inhalers to be able to basically do the same kind of a thing and reduce any inflammatory component. Today we use phenylephrine. This is nasal decongestants. I'll give you the backstory. When amphetamines were first discovered, is the wrong term. When the pharmacological community in the early 1900s, they discovered that a Chinese tea called ephedra had very interesting things. They were taking it for people with difficulty breathing. It's had a chemical called ephedrine. Ephedrine was then, they saw that it decreased appetite, it increased alertness and awareness. It was a psychostimulant, and that as well as being able to enhance breathing. Eventually, it was tinkered with chemically, and it became something called benzodrine, which was the first amphetamine agent. It was available without prescription. He was used extensively in World War II with pilots flying multiple sorties. Adderall is still used. So we're still using that in the military to enhance awakening. Obviously, there's guidelines and there's potential for problems with it unless it's not used intelligently. So that is how it was first used. As time went on, we developed them for people who would take antihistamines that could the early antihistamines, not like the Zyrtex of today, which are very effective for both, but the early ones were made you very drowsy, like Benadryl and Actifed, which is chloramphetamine. They mixed it with this for nasal decongestants. It was called Sudafed. No longer used today. Now, if you get one of those, you can buy pills, you can buy sprays. Phenylephrine is for nasal decongestion. The reason they stopped using the Sudafed is that was people started to make amphetamines with household ingredients. It didn't take like they did a whole television series, Breaking Bad. It was very, very successful on AMC with that. Anybody with your degree of chemical knowledge could do that. Somebody took OChem, they can do that. Trouble is, it's a very hazardous thing to do at home because there's so many flammable substances. And the secret ingredient, so to speak, was Sudafed. And so the farmer, you should be able to buy as many as you want. And they just, somebody would buy all the Sudafed tablets they had, and you break them down and you use that. Then they started to, because I was taking a cold pill that had, and they started, well, I need to see your driver's license, and they'd record it. If I'm coming in and getting, one every 3 months, nobody cares. If I'm getting, 20 every other day, suspicious. I just went to no, I didn't go to a lot of pharmacies. And so sympathetic, and these were the early blood pressure things. Drugs called beta blockers block beta receptors, decreasing blood pressure. We now decrease blood pressure by more, I'm trying to say, useful means. We'll finish up this chapter on Wednesday with this idea of dual innervation and cooperative effects. And say we don't have a lot more to go with. Thank you. I'm going to see if we're here or there. Give me a second.